clock is running, so without waiting more, I want to share with you several words about the mission of our endovascular course. In fact, we started 18 years ago as a small symposium of Biotronic company. I think Biotronic was acquired by Teleflex several months ago. So we started with a symposium of a non-existing anymore company, and on the next year, in fact, in year 2009, we started with the first endovascular course with the name Endovascular course. Endovascular, Jacques mentioned in the morning, endovascular was a new idea. It's a way of thinking, and because of that, we are dedicating every year with one meeting omitted during the COVID pandemic, but otherwise you are assisting now on the 15th edition of the Balkan endovascular course. So we are together, as you can see very well, we are together people from many different specialties: cardiologists, radiologists, vascular surgeons, cardiac surgeons, anesthesiologists, neurologists, neurosurgeons, and so on. This is the idea: to be together, to be collaborative, to learn. In all the meetings since 18 years, I'm learning a lot during this meeting. So this is very important. The medical practice and the medical science is in fact like the universe. It's not possible to learn everything, but it's very, very, very important always to learn, to continue learning. And the education content definitely is very important, and all of the surrounding people, we are participating in the scientific content, but in fact the educational part is very dependent on the support. So we have to thank the support to the companies, because without the support of the companies, the education content cannot reach the audience. And in fact, I mentioned this morning, Ted Dietrich, he is a giant, he is like our God. He was an amazing personality, a real pioneer, a real human being, and for us that we touched him, we touched his personality, it was really a special event for life. For me, knowing Ted Dietrich was really something that changed my life for sure. And having the testimony of Ted Dietrich, and we continue to organize this meeting as the local meeting of the International Society of Endovascular Specialists. And in fact, this is the mission. This is the mission: to be together, to be collaborative, to be multidisciplinary, and to help the patients with all our common and unified efforts. I would like to ask Jacques, Klaus, Iris to say several words, and with this to have the possibility to continue together and further.
As I told this morning, this is the heritage of Dr. Dietrich, who trained me, who trained Dr. Donald Reed, one of the most appreciated fellow. You are now president of the foundation in Phoenix, so you have also the heritage. Here in Bulgaria, you did work with him. He did some case with you. And he was interviewed by the Ministry of Health, that you know. So you have big support from him in the memory, from your partner, from your colleague, and your friend, We are your friend. Thank you.
Iris, neuroendovascular is one of the target of this symposium. This is probably the field that is going up the fastest way. So, Iris, thank you for coming.
Ivo, I cannot thank you enough for organizing these meetings. You have really managed to combine so many fields from all specialities, because there's a lot we have in common. There are a lot of different techniques, and there's so much we can learn from each other. You're an inspiration to so many with what you have set up and how you manage to support the whole field and how you bring the societies together to really collaboratively work with each other. Thank you so much.
Professor I will Mathias. Make it very short. I'm here coming now, I feel, at least 30 years, so it must be much longer time that this event here happens. And perhaps I come the next 30 years, yes? I will see that.
You'll always be invited.
Thank you.
For sure. Thank you. And I would like to ask Rebecca. She's a present board member of IFCVS. Please, Rebecca, please come. And Donald, please. One of the biggest supporters of our meeting is Donald Reed. Jacques was the initiator of creation of ISEVS and present ambassador of International Society. Donald was, in fact, he is now president of the foundation that was built by Ted Dietrich, and one of the ex-president of the society. Excuse me, because Donald was one of the president, and in fact, Donald coming as a proctor for a AAA case was the reason me to know Ted Dietrich. Thank you.
Ivo, it's wonderful to be here again. Like Dr. Mathias, I am so old, I was at the very first Congress. I've watched it develop beautifully. You do have all of the hot topics on your meeting. I find it funny we're all jumping from one room to the other to see them. I also love the live cases. I think it's very, very instructive, important for us. I love the way you applied intravascular ultrasound on a patient who had just been treated 2 weeks ago for symptomatic carotid disease. And there was uncertainty, should you treat or should you leave it? And you found out with the intravascular ultrasound. It was beautiful to watch. So congratulations, it's wonderful to be here again, and can't wait for more live cases later.
Thank you for coming.
Oh, thank you. Thank you, Ivo, for inviting me. I'm so proud to be here. I'm so happy. And I want to invite you to all, if you want to participate with us and the International Society of Endovascular Specialists. It's open. It's very useful to know people from other sides and to have the idea that endovascular procedures can be done by each one of us, and each one can learn from the other side, from radiologists, neurologists, cardiologists, and vascular surgeons. So the field is open, so I invite you to participate with us. It's very, very, very important to have all the kind of mind, all the different point of views for each one. So I invite you all to participate with us. Thank you, Ivo.
Thank you, Rebecca. Thank you, all of you. In order not to spend too much time and to occupy the time for science, I announce the meeting open. So let's go. Go ahead. Thank you so much.
Yes, I have to correct Ivo. He said yesterday already, that morning, that there are colleagues from 3 continents. It's 4 continents, because our next speaker is coming from Scotland. And that is between Europe and the United States. It's an own continent.
Well, and it really shows that as a neuroradiologist, I am here today talking about the heart. I would not have had the inspiration to work on heart models had it not been for our multi-society collaborations. And thank you again also on behalf of the World Federation for Interventional Stroke Treatment. I'm going to talk to you today about a novel perfused human heart model. This is something that is currently unique. We have developed this over the last years. I have no conflict of interest regarding this presentation. Now, as Klaus was already saying, we are located here in the city of Discovery in Dundee, and this is our research center. I would ask you for this presentation not to take any pictures or videos so that we comply with the Human Anatomy Act, because I'm going to show you cadaveric images. This is our setup, which is only for device testing and training. So we've got a DSA angio and a dedicated photon counting detector CT, which you see in the background. Now, most of you also from medical school, you will still remember the typical cadavers we had, which are fixed, you cannot bend them, and definitely the vessels are not open. Now, what we have in Dundee is a human perfused cadaveric model where everything remains soft and flexible, and we have for the first time managed to also keep the vessels open. Not only that, we are also able to ventilate the lungs, and this is in a dead body. We're able to ventilate the lungs, and we can cannulate the aortic arch in order to do intracranial procedures. You will see that this looks exactly as it would in a live human being. We could have a clot here in the middle cerebral artery, and also we've managed to keep all the branches of the external carotid open. And this is what we usually use for training interventionalists on how to perform thrombectomy procedures, because we're training interventional radiologists, cardiologists, interventionists from across the team on how to become experts in interventional stroke treatment or in carotid stenting. And recently, last year, we also managed to get the veins open. Now, and you may have heard about our first transatlantic thrombectomy that was performed in Dundee using the human cadaveric model. Okay, so about the heart, and what we first wanted to know is this model even suitable? Do the coronary arteries react the same way as they would when you're cannulating it? Can we keep those vessels open? And you see here a DSA angio of the right coronary artery and of the left coronary artery. But it's all nice if we can get that done once. What we wanted to see is this replicable, and what do experienced cardiologists think about this model? So the first thing we tested was navigation, and is the anatomy okay? Then we looked at a stent retriever thrombectomy and aspiration thrombectomy, at coronary stent implantation, and at balloon angioplasty. So here an example of a coronary injection. And what regarding cannulation of the different vessels, all 5 operators found it feasible, and it was possible in all the cases. And in addition, we performed IVUS and checked whether we can also do IVUS in these vessels. And yes, it was possible. So next, we develop clots, and we do that especially if we have companies who come for device testing. We can have erythrocyte-rich clot, we can have fibrous-rich clot. We have a limitation with the human model. We can only use human blood, so we cannot use animal blood for this, but probably I would say it makes it even more realistic. And here we can, because we can stop the flow and the pulsatile movement of the heart. So here you can see how the clot can be pushed, controlled into the vessel that we really wanted. So the first thing we did is injected the thrombus, and we did aspiration procedure, first with a 3 French catheter, the penumbra 3 max, and then with a 6 French Sophia catheter to see does it work in the vessel anatomy, and yes, it did. And so it was possible to place the catheter in all cases, and it was successful in retrieving the clot in 60%. So in 2 cases it failed. Now, what would we do in the brain if aspiration fails? We would use a stent retriever. I know that there's companies now who are developing stent retrievers for thrombectomy. And what we did, because I didn't have one of those, so we used one of the neuro stent retrievers. This is the Stryker Trevo here. And you can see how the stent retriever was deployed, and here how the stent retriever then is retracted. And again, did an evaluation, and yes, it was possible to do this in all cases. And and in one case we needed 2 retrievals, but with that we managed to get the clot out, which was then confirmed with IVUS in each occasion to see that there's no residual. We also performed coronary stenting, and then tried some different scenarios, because by now we knew this was going to work. And we tried first the standard implantation with 2 different stents. And then we did a deliberate malapposition and post-dilatation to see whether the post-dilatation would fix it a little bit. We did repeated IVUS, which then confirmed that there was an improvement in stent apposition. And then we simulated a perforation and implanted a covered stent, and again confirmed with IVUS about the position. Balloon angioplasty was one of the last things that we did, and yes, balloon angioplasty also works and was thought to be realistic. Now, with that, we thought, why not go on to the structural heart? And we went on, because previously we had no movement here, and we went on creating flow. And what you see here, first the aortic valve and then the mitral valve. And this is so special because in a human, you have blood and you cannot film, you cannot see what's happening. Whereas now we can see the exact deployment of a device and we can film whilst the procedure is being done. Here, an example of an LAA closure. Where at the top you see the pre-intervention ultrasound and then the post-intervention ultrasound after it's deployed, a CT, post-control, and also then a 3D reconstruction of the position and of the device. And next, coming to the imaging. So we have got 200 cadavers available at any moment. So we've got the biggest repository of the cadavers, which means that especially for device testing or for certain training scenarios, we can choose and select cadavers. And it may have something to do with the Scottish fried Mars bar, but our vessels, our patients have usually very calcified vessels. You can see all the calcifications, which turned out to be really useful when it went to the next step, and that was to test lithotripsy.
It's well done, the LED. That's good.
And here the chest plate was taken off because the clinicians also wanted to feel what the difference is and what happens during lithotripsy and whether the vessel feels less stiff afterwards. It did. And finally, you also saw our, I mentioned earlier on that we have one of the 3 mobile photon counting detectors. There are currently only 3 in the world. A photon counting detector is a new kind of CT where you have a 10 times higher resolution with less radiation. And you can do another special thing. You can look at material decomposition. That means you can see what energy value each material has. So the first time you could differentiate, for example, between blood and contrast extravasate if the Hounsfield units are the same. So I can tell it exactly the energy value that I have. It's similar to dual energy CT, except that it can do any energy. You don't need to define it beforehand. You can do it retrospectively. So we used that, and we used it here to look at the resolution, and you can see here also the resolution of a coronary stent, and we looked at the degree of stenosis and looked at what energy value do we have the best assessment of stenosis. The FDA thinks that photon counting CT is going to replace any CT in the next 10 years. So I think at the moment, we're just at the beginning of a revolution here. And I'll just show you one other thing, because this is, again, something that will be possible. And that is to look at the energy value of different contrasts. So this is a normal high resolution CT with the PCD scanner. And here we used an iodine map, so meaning we can now say that we put iodine in this part of the heart, whereas in this part of the heart we put gadolinium. We put blood in this part of the heart. So it gives us the possibility of using different contrasts to different media and differentiating them. Model has since been used in many, many training sessions and been evaluated both for stroke and for the heart. But what we believe is that this is the ideal training model for the future for training interventionalists to not only do catheterization or thrombectomy procedures, angioplasty and stenting, but also on LAA closure, EVA, TIVA, transcatheter aortic, and the mitral valve replacement, or even on the lithotripsy. Thank you so much for your attention.
So, yes, thank you very much, Iris. And are there questions? If not, then, oh yes, there is some question.
What is the smallest vessel that you can put a camera in?
We haven't tried which one is the smallest vessel, I have to say. So the limitation would be probably the stiffness of the vessel for intracranially, on whether or not we can bring it up. But however small the camera is, if it's small enough to fit into the vessel, we can oversize a bit. So if the camera is, say, 3 millimeters, we could bring that in a 1.5 millimeter vessel.
A short comment. When somebody of you want to train in this special endovascular technique, or you have colleagues, young colleagues who should be trained, I recommend them to go to Dundee and Iris, because they have a really wonderful training center there.
Yes, so this is what we have set up.
One of the best in the world.
With the World Federation for Interventional Stroke Treatment and together with BEC and interdisciplinary societies. So what we do is we provide accredited training and help in the setup of thrombectomy centers. So I'm a neuroradiologist, so obviously that's more my specialty, but if there are other fields where you want to be trained, Michelle, my colleague, and Anna are here as well. So if you have any idea, we're also providing a special WIST-BEC course dedicated to this conference, which if you approach Michelle and we'll have some flyers, then you're very welcome to sign up to that. And it's one opportunity to use that. Thank you very much.
Thank you, Iris. Dr. Grunwald mentioned X-ray reduction. Now, Professor Mathias will share with us how important it is really to have protection and X-ray reduction in our practice.
Yes, it is very, very important, as you will see in short. So first angiogram, 1 year after detection of radio beams, and then 20 years later, the first report of radiation dermatitis. And that was then the reason why protection started, because in the beginning there was no opinion about biological reaction to the radiation. Angiographic suits have developed over the time, so we have now quite different solutions, much, much better, with much, much less radiation exposure. And when we talk about radiation exposure, we have in view the patients and also all the workers in the angio room. So we have there the patient. Mostly of them have a single treatment or potential intervention, but those who are working in this control area, they have daily exposition and they need, therefore, protection techniques. Skin reactions after radiation that concerns especially the patients is erythema, depilation, ulceration, and skin carcinoma. You see here 2 examples, one after a long long-lasting cardiac intervention. And I have also to mention that the patient, when he is feeling well and he is sent home after 2 days, these reactions are not immediately there. They come with the following weeks. And the same is also, you see, with neurointervention, yes? There are no hairs anymore, so that was also a very high dose. Normally you should not have such a high dose. Another cardiological case, yes, you see erythema and also necrosis of the skin. Yes, that was 1 hour of fluoroscopy time, additional the angiograms. Normally, when you work experienced and well, you need only 10% of that dose. And when you have a complex case where you have a high dose on the skin, change the position of the C-arm a little bit, and then you have it not on the same spot on the skin. Yes, you see that until the skin reacts, it's some weeks until you have it all, yes? So the first 2 days, there's nearly no reaction, perhaps a little bit of itching of the skin. And yes, never have your hands as an interventionalist in the beam. You see here a cardiologist who developed skin cancer. So he was a right-handed man, as you see, and but also left. I don't see any hairs there. You have also the scattered radiation, because that's the radiation coming out of the patient. You know, we have radiation beams who go through the patient. We have those who are completely absorbed, and we have the scattered radiation. And the scattered, yes, will hit you, and it has a high energy, because otherwise it would not come out of the body of the patient anymore. And therefore you have to protect yourself. And as you see here in this case, yes, right leg, no hairs anymore. Perhaps some ladies like that, I don't know, but it's better than to use a different techniques. And on the other side, you see somebody who still has. The same is also, those carrying an umbrella have an advantage because it absorbs some radiation, and we have also special umbrellas with lead glasses, and that will prevent cataract development. You have heard already several times today of Ted Dietrich from Phoenix, Arizona, a worldwide known vascular surgeon. Yes, but he was also not so, conscious about radiation exposure. And then he developed a brain cancer, a brain tumor, a malignant brain tumor, from which he died after a couple of months. So be careful. When I do an angiogram, I always step slowly back, not too fast, otherwise the patient is anxious that the doctor is running away. But a little bit, because you know that the distance matters quite a lot. Yes, we have biological effects when the X-ray beams are hitting cells. The lymphocytes will be reduced, and that also weakens the immune system. That is also, there are several scientific examinations to that, and you see here one example, yes, where they detected that, yes, endovascular operators had some chromosome changes. Some of them might be repaired, but otherwise the cells are lost more or less or develop tumors. The radiation protection starts before intervention, so you have to have a plan. What will I do? What for instruments will I need? What for devices? And so on. And then keep radiation exposure as little as possible. So when I look at that, yes, what is wrong here? First, the lead shield is not used. Second, I see also that the receptor is fairly high, above the patient. Also that increases more. What is wrong here? Yes, 2 people should be in the room, but not all of them. We don't need them there. They can be outside and look from outside into it. Very similar here, yes. Why do they have all these people there wanting to see something? So they have no right to be there. So be well organized, because as you see, physicians receive the highest dose of radiation. It's more than double as what your technician or your nurse will have, and the patient has the lowest. So use the protection screens, because they will absorb most of the radiation. Use glasses, especially lead glasses, yes, and so on. So when you use all these techniques, yes, you reduce considerably the radiation exposure. So when you want to minimize that, rule 1, small radiation exposure of patient means less scattered radiation and reduced exposure of persons in the angiogram. And second, use an image quality which is sufficient to be for the intervention. Yes, so not the highest possible. Pulse fluoroscopy, we have that, yes. You know that our eyes are much slower than that of birds. So when we have 25 to 30 pictures per second, we see it as a film. Not birds, they need 50 to 100 pictures per second to see it as a film. But we don't need these high rates, so in most cases not. Must be exceptions, IV shunts or so, where you want a higher rate. Yes, and we have interventions where you have a low dose, recanalization of a lower leg artery. It's not a radiation problem normally, but there are complex interventions, yes, where you have higher doses for the patient as well as for the physician. Like that. Yes, when you have such a repair of the aortic arch aneurysm, and you have to also find ways to all the side branches, because you must preserve the blood flow in there. Then we have another risk, that is, as you see, when the patient, and 30% of our patients have too much weight, you have much more scattered radiation, and the image quality is bad. I have also used there a special technique. I had there wrapping around the patient something, and I pressed him. But first I told him that when he is not getting any breath anymore, he should tell me. Because every 2 to 4 centimeters, the dose is doubled. So it's not double as thick, double the dose. No, it's exponentially. And therefore it's very important also. Yes, you see the professional exposition is dependent also on the position of the physician. So the first operator has the highest scattered radiation dose. So how do I protect myself? As already mentioned, planning, then optimal use of radiation technique, keep a good distance as far as possible, hence never in a radiation team. I have also seen during congresses live cases where sometimes the hand is in the radiation beam. That should not happen. Use all the protection devices. Doses should be below per year, the lens dose. Use the protection device, but don't throw them in the corner, because then the material is broken and you have no protection, even when it looks intact. Then use the protection shield, We have even additionally to that, yes, you see a flexible lead. When you want to look like a knight, then you use also these devices, yes, then you are completely protected. Then what is also important, yes, how to place the X-ray source, your X-ray tube. It should be the better way is when you place it below the table. You see the difference. Then you have more scattered rotation to the upper part of the body, but you have other advantages. I show it here again. So that is the best. The table is high as possible. Naturally, that depends on the height of the interventionalist, yes, but high. The detector is close as possible to the patient. So you see it on the right side, that's the best option. And that matters also when you look, yes, at the doses here. And so we have also dose management systems now, so you have permanent control of what for a dose you have received. Use shutters, because then also you reduce considerably the scattered dose. You see it here again. Use shutters, that's an EVOD. Yes, then also use restrictively series. Yes, you need to have a series when you start and when you end the procedure, but in between, yes, you must not do an angiogram and again and again and again. Last image hold sometimes is enough when your angiogram sees. Also the low dose or the high dose of fluoroscopy, you see the difference here, but low dose is in many cases enough. Also the same roadmap, use it, you can measure the diameter of the vessel, you can make your selection of a standard and whatever. And you see also experience of the intervention list is very important. When you look at this list, then you see, yes, there are some who look at the bottom, nearly no exposure, and others have more than 10 times that, yes. So also that is important how you do it. Yes, develop a culture, and you should know your annual radiation dose. Training, we have just heard it with the heart, and there are also computers where you can train, even in the internet, you can train that. And so, many thanks for your attention.
Thank you very much, Dr. Mathias. Very important, very interesting. All we know that sparing contrast and sparing X-ray is very important for the patient, and it's very important to protect ourselves because we are not eternal. Iris?
Very much. How do you see the future of robotic interventions in that aspect? Because it is not just to do this remotely in areas that are that do not have access to a specialist, but it could also work doing it from the control room.
That will have a positive influence. That will reduce the dose considerably. Yes. When you have general anesthesia, yes, all the personnel can go out of the room, with the exception of the anesthesiologist, but he can have a protection.
And
here.
one final question. Pregnant lady, you need to do an intervention. Pregnant lady,
yes.
You need to do an intervention. Do you put lead shielding around the tummy or not?
Yes, it depends where you do the intervention, yes. Well, if it's the head or is it the abdomen, yes, or peripheral, that depends on that. Mm-hmm. When it's possible, certainly.
Or would it cause scatter radiation?
Yes, you can protect it only partly. It's also dependent, yes, how far in the gravity the lady is. It's the first 2 months or is it month 8? Yeah? But normally, yes, protect as much as possible. But also the baby will have scattered radiation when you work in the chest, yes, there will be radiation also, even when you have a lead apron around the patient, that is not zero.
Thank you.
To share our home-based experience with the protection, we used old aprons and place one apron below the patient crest and back, and the second one is placed on the table just at the place of the generator. And this, by combining this, we decrease the dose for the personnel around 15 to 17% in different months. Because we follow this very, very simple, just one apron below the patient, for the cardiac procedures, I mean. And just at the level of the detector, because when you all the LEO projections, you have the generator some scattered radiation. So this is very simple, and this is way you can use old aprons for protection.
And if your apron is still working completely, so every year we place them on the X-ray table and take a picture, because then you see if there are already damages. But you will not feel outside.
In case no more, thank you very much.